We spent part one discussing the impact of identifying disease early and discussed some strategies to assist in making a strong patient-provider connection and strengthen the ability to find time for prevention. Today, we're going to scratch the surface a little bit in regards to the epidemic of cardiometabolic disease. When you look at statistics, it's alarming to say that, today, 45% of Americans have a chronic condition, and more than half of older adults have 3 or more chronic conditions. That's a lot of people with chronic conditions. Particularly common are the cardiometabolic diseases, including cardiovascular disease, type 2 diabetes, non-alcoholic fatty liver disease, and chronic kidney disease. Welcome back, Jessie. Betsy, I'm so happy to have you here today. So thanks for joining us again.
Thanks for having us.
Thanks for having me back.
So given these statistics, 45% of Americans with chronic conditions, older adults, 3 or more chronic conditions, do you think that this is comparable to what you're seeing in clinic?
Absolutely. I would say it's 100% consistent with what I see in family practice. And I would say even not older adults, younger adults, children. I mean, we're seeing these diseases so much sooner than we used to. Given this growth in the obesity epidemic, I think we're only going to see more of it. So I do think it's such an important topic to kind of dive into more, identifying disease early, understanding that even though BMI is a tool, it's not gold standard for health. I think it's important to look at all the risk factors, understanding that health can be at different weights too. But a lot of these diseases do run together. And so I think we have to start looking at that common denominator and really looking at all of the risk factors to optimize your patient's health.
100%. She's right on that. We already know that obesity is one of the basic factors for hypertension, for dyslipidemia, and diabetes. And as those things progress, they can ultimately affect other major organs. So yeah, it is important that we look for it. We don't want to just wait for it to happen in our office.
These numbers are continuing to increase, right? You have 11% of the population with diabetes, a majority of those being type 2. 1 in 7 Americans have chronic kidney disease. 25% of the globe has NAFLD. I mean, when you start to hear these overwhelming statistics, one needs to think, what do we need to be doing to address this epidemic? We've had all of these advancements. We've had better medications, we have better procedures, we've even convinced a few people to stop smoking along the way. Why do you think this epidemic of cardiometabolic disease is happening? There's so much you have to pack into that 15-minute appointment, but really, the purpose of our time here today is really talking about why we need to figure out a way to get it in, right? I mean, this is, continuing to expand as far as an epidemic. And I think there's some component of lack of awareness and recognition. Would you agree?
Oh, of course.
100%. Yeah. I think that most of these diseases you won't see until they're more advanced. I think as a society, we're, not focusing as much on health and focusing more on productivity to get that gold carrot to try to be successful. I think access to healthy foods, time for prepping healthy foods, time for exercise are all limited. I think for some patients, it feels really daunting when they think of these diseases and how they have to make this huge change. But I think it's important to focus on the small changes, making one small change at a time. If you have a patient that walks in your room and they've got the 3 Ps, you're thinking, oh man, this is going to be a toughie, right? They're thirsty, they're peeing a lot, they're hungry, and they're like, I don't know what's wrong. And I'm like, I do. And so you get that A1C and you find out it's greater than 10. And it's so much harder to reel in a disease that's already so out of control as opposed to that preventative piece. So I think we need to be looking very early, and we're not going to see those patients really early with symptoms. And so it's really so important to identify patients with your preventative tools, with your physical exams, with your health histories, making sure that you're getting them in for their annual physicals, for their routine, laboratory testing, checking their blood pressure, seeing it as it's trending, seeing as any kind of vital sign shifts, and it's catching those things early, because if you're catching them when they're symptomatic, then it is not a fun thing for the patient or for you to have to handle then.
We do need to be more aware for them, is what I would say. We really just have to keep looking. We just have to be very surveillant for them.
Yeah, and I like your point about we have to keep looking. And I think you both highlighted some really key points here, right? You have, the societal components. I think that, so many things have changed over time in regards to how we live our daily lives. So, that is, I think, an important focus, tying back in that lack of awareness and recognition. It can be alarming how many people that are pre-diabetic don't know about it, or that have chronic kidney disease aren't aware of their diagnosis, and the same with cardiovascular disease and NAFLD. So really highlighting, that silent component contributing to why this is happening. The other thing that I like to bring up when I talk about this is, are we asking the right questions to truly identify risk factors of these cardiometabolic conditions? And I think this ties a little bit back to what we talked about in part one and taking a great history. But are we asking the right questions to really risk stratify these patients or identify these risk factors that they have for cardiometabolic conditions?
I think one major one, of course, is family history. I mean, taking such a good family history is probably one of your best tools, even before a physical exam for many of these diseases specifically. Asking about diet and exercise. I would say that unless it's like a cold or something, there's probably not a patient that walks out of my office that I haven't asked them, what is your lifestyle like? What is your sleep like? What are you eating? Are you eating a lot of processed foods? Are you getting the recommended amount of exercise? Anybody that walks in, again, even if it's not always for that, I'm symptomatic with diabetic symptoms, or I have headache because I have high blood pressure. I mean, if you take the time to ask those questions, you're going to identify risk there. And that's going to make you say, okay, well, I see that your dad had a heart attack at 50. That's a little concerning. I know you're here for your back pain today, but maybe next time we come in, let's get some tests and we can focus on that a little bit more, because that's going to increase your risk.
Such great points. I think you hit on so many components to patient history that can contribute to risk. I think my only additions to think about would be chronic inflammatory conditions, or even thinking about asking about adverse pregnancy outcomes. Individuals outside the spectrum of OBGYN do need to know about pregnancy history within our patients.
Oh, yeah.
There's increasing literature to talk about the association of long-term, cardiovascular risk from adverse pregnancy outcomes. So adding those components to your history is going to be beneficial when we're thinking about risk factors. So, great insight.
I think with patients, sometimes they have a slew of symptoms and they don't realize, as a clinician, you can look at those symptoms and you can clearly see that they do highlight a single disorder.
Yes.
But sometimes patients don't see that, if they are, again, with the 3 Ps, they may not know that has anything to do with diabetes, So I think sometimes they'll write down those symptoms that they're having and they think they're all just independent symptoms, totally but they really are a symptomatic disease.
You're able to connect the dots.
Exactly.
But you need all the information to do that. So again, even tying back to that importance of history taking. Now, evidence continues to expand in regards to the interrelationship of cardiometabolic conditions that I spoke about before, CVD, type 2 diabetes, chronic kidney disease, and non-alcoholic fatty liver disease. I have to be honest, and many providers may feel the same way listening to our talk today. Hopefully they can relate to this, but I think sometimes you can get tunnel vision in care. You're so focused on treating their cholesterol or treating their uncontrolled diabetes, you lose sight of the need to look at the spectrum of disease that they may be at risk for. Can you touch a little bit about the importance of avoiding that tunnel vision that I speak about and expand on how these conditions are interconnected?
If one person has one disease, not only are they at risk for 2 or 3 of these others, because diabetes almost always has a little bit of fatty liver disease associated with it. And high blood pressure can have chronic kidney disease, and all of them can have cardiometabolic. All of them relate to your heart health. I mean, diabetics don't die from diabetes, they die from cardiovascular
everything else.
And kidney disease and other things. So I think that you have to look at all of them, but it is really easy to just be like, okay, today we're focusing, because again, it comes down to that time strain. It comes down to the time constraints. So it is really important to kind of look at all of those comorbidities to start thinking about these things earlier, because again, if mom, dad, brother, sister all had diabetes, or they had obesity, and they passed down these habits to them, these genetics to them, we need to check earlier. And so I do find that doing things like the insulin resistance, checking for insulin resistance even before this, so that you don't get that 10 A1C as a new diabetic walking in your office. And then you're also checking a microalbumin, you're checking for chronic kidney disease, you're doing your GFRs, you're checking liver enzymes. I mean, you have to look at the patient holistically, but it is so easy to just fall into the trap of like, okay, well, your A1C is so bad, we have to just focus on that today, but you can't, because they all make the disease process worse.
Right. And, that's where frequent follow-up comes into play too. When you have somebody that you're newly concerned with, you do have to bring that to light. And, they aren't happening in isolation. And it is part of the bigger picture. And that's one of the advantages of family practice that I had. I took care of people from womb to tomb in my very first practice. We really had a very comprehensive practice. And knowing a family and taking care of a family, well, you can start identifying stuff in those kids right off the bat, which is another helpful tool, because it's happening with our young people now.
I think also focusing on the treatment of obesity is important. Right. So trying to get familiar and comfortable with treating the disease process that may be a precursor to a lot of these problems can be so helpful at preventing these other disease states. And so I think it would be a great standard to start to just get familiar and comfortable with medications and conversations associated with just weight, without chastising patients, not making them feel bad, and showing that you're a support for them, that they're a cheerleader for them, that you want them to get healthier. But a lot of it comes down to being comfortable with sometimes treating that initial disease process before those other things happen.
You make such a great point with that. I think as providers, as a whole, being advocating more to address that underlying factor, if it exists, is going to be beneficial in the long run. Another point, I think, if our audience takes any tidbits away from this conversation, your focus on early identification, truly improving clinical outcomes is key. I think you've hit on it a few different ways throughout our conversation, in the silence of disease, and then how, these often are interconnected, right? So when you see one, start looking for another. So really
Absolutely.
those two points are key, is that early identification improves, clinical outcomes long-term. And once you see one of these cardiometabolic conditions, that you're on the hunt for another, or at least paying attention to the potential that they can occur, and are at increased likelihood of occurring. Betsy, Jesse, your patients are so lucky to have you. I mean, your thoughts and your strategies to overcome this epidemic. It's not going to happen overnight. But thank you so much again for your input and education this session, highlighting the epidemic of cardiometabolic disease. I really appreciate it.
Thank you so much.
Thank you.
The detection of these conditions that we discussed today in their early stages, when clinically silent, provide opportunity for a stage-targeted intervention and improved clinical outcomes. Coming up in part 3 and 4, we'll discuss our cardiometabolic approach and laboratory insights available at Quest Diagnostics to assist you with early identification and intervention. Thank you for joining us.